Hello, everyone. Welcome and thank you for joining us for today's presentation. I am Lizette Gutierrez, coordinator of this event. This event is part of the UT Health Houston Institute for Implementation Science seminar series, which features lectures by leading experts in the field of implementation science. Registration for upcoming seminars and recordings from past events can be found on our website. We have a few quick announcements before we get started. The seminar is being recorded and the recording will be posted on our website after the event. All microphones are muted. If you have any questions or comments during the seminar, please enter them in the Q&A box as there will be time for questions after the presentation. We are pleased to offer one MChess credit for today's seminar in collaboration with the Michael and Susan Dell Center for Healthy Living, housed at the UT Health Houston Public Health in Austin. The Michael and Susan Dell Center for Healthy Living is a designated provider of continuing education contact hours for certified health education specialists and master certified health education specialists through the National Commission for Health Education Credentialing. If you requested chess or MChess credits, you will receive an email 1 week following the webinar to complete an evaluation. Please keep an eye out for this in your inbox. We'd like to give a big thank you to the Institute of Implementation Science members for attending today's event. Our members receive perks such as access to our networking events, educational opportunities, and the opportunity to speak at our seminars. If you are interested in becoming a member of the Institute for Implementation Science, please visit our website for more information. Now, I would like to introduce Dr. Maria Fernandez to introduce today's speaker.
Hi, everybody, and welcome. We're really excited. This is the kickoff of our 2025 Implementation Science Seminar Series. I am the Vice President of Population Health and Implementation Science at UT Health Houston, and also a co-director with Dr. Bijal Balasubramanian, who's here. Want to say something, Bijal? Hello.
Hi, everyone. Yes, and really excited to kick off this year's seminar series, and no better than Dr. Beidas here. So Maria, you can go ahead.
So it's my distinct honor to introduce our esteemed guest, Dr. Rinad Beidas, a nationally recognized leader in implementation science and behavioral health. Dr. Beidas currently serves as the chair and Ralph Seal Paffenbarger Professor of Medical Social Sciences at the Feinberg School of Medicine at Northwestern University. Prior to joining Northwestern, Dr. Beidas held several influential roles at the University of Pennsylvania, including the founding director of the Penn Implementation Science Center at the Leonard Davis Institute and director of the Penn Medicine Nudge Unit. Her groundbreaking research integrates implementation science and behavioral economics to improve the quality of care across a wide range of health domains, including mental health, cancer, HIV, cardiovascular disease, and firearms safety promotion. Dr. Beidas has authored more than 300 peer-reviewed publications, super impressive given how young you are, Rinad, in leading journals such as JAMA, New England Journal of Medicine, Catalyst, and Implementation Science, and has served as the principal investigator on multiple principal investigator on 14 NIH funding grants, totaling approximately $45 million. She's also the deputy editor-in-chief of Implementation Science, which is the flagship journal in the field. In addition to her research and editorial leadership, Dr. Beidas contributes her expertise to several national advisory bodies, including the National Advisory Mental Health Council and the National Academies of Sciences, Engineering, and Medicine study on building a national prevention infrastructure for behavioral health disorders. Please join me in warmly welcoming Dr. Rinad Beidas.
Thank you so much, Dr. Fernandez and Dr. Bala, for the invitation, and a big thanks to Lisette, who was an incredible patient support as we got to this presentation. I'm going to go ahead and share my screen. And can someone give me a visual indicator that it looks right to you?
Yeah. Well, it says continue to share this. Yes.
Got it. Thank you.
Perfect.
I wasn't looking at my side screen. Thanks. I appreciate that. Wonderful. So it is a delight to be here today. I'm going to try to cover a lot of ground, so I will talk fast, but also I encourage you to put questions that you have as they come up in the chat. I really want to do like a big picture overview of some of the thinking of various teams that I'm a part of are doing at the intersection of implementation science and behavioral economics, and give you a flavor for this work, but not go super deep on any one topic since there's so much fun stuff to cover today. So looking forward to that. I do want to start my presentation by thanking the incredible teams committed to really bringing together work at the intersection of these two disciplines. This has been funded by two P50s, one from the National Institute of Mental Health, the other from the National Cancer Institute. And the individuals pictured here were thought partners and leaders in this work: Kevin Volpe, David Ash, Allison Buttenheim, David Mandel, Justin Beckelman, Robbie Schnoll, and just want to call them out because I'm here presenting this work, but it is very much on behalf of the incredible team. So my talk today is organized into 4 chapters. I'll start by doing a little bit on my view of what implementation science is. I know this is a seminar of folks who are all well acquainted with implementation science, but it is still a growing field, and I think it's helpful to do a little level setting about how I kind of see the world through that lens. Then I'll spend a good portion of time introducing the group to concepts from behavioral economics, and then give you some exemplars of how we've melded the two disciplines to move the needle in health. And then we'll close with some implications and future directions. So first chapter, we'll try to go fast, given I know that all of you are well acquainted with what implementation science is. But I do like to start by sharing that my identities and lived experiences shape my perspective. And you can see here on this person figure some of the identities that I identify with. And one of the reasons I'm so excited to get up in the morning and go to work with and do the work that our team does is I see implementation science as a tool and a method. And it allows us to advocate and amplify for the needs of our communities in pursuit of achieving population health and social justice at scale. And that's really the orientation that I kind of come to this work with. And have had a deep commitment to this over the course of my career. As Dr. Fernandez shared in my very kind introduction, I was at Penn Medicine for over a decade, where I had the great privilege of building a program in implementation, research, practice, and education. At all the missions were covered through the Penn Implementation Science Center and the Nudge Unit. And this is now my 4th year, which is, it's incredible, time flies, at Northwestern Medicine, where I have the honor of serving as chair to our Department of Medical Social Sciences. And I do want to just pause and tell you a little bit about medical social sciences, because I think we're a really unique special asset that we have here at the Feinberg School of Medicine. So we have 90 PhD social and behavioral science faculty who partner with our health system and communities to advance priorities across the public health continuum. And it's really special to be in a department focused on methodology, impact, equity, and innovation. So I do like to share the main takeaway from the talk at the beginning. Takeaway, I meant takeaway. The main takeaway from the talk at the beginning of the talk, because I think it helps anchor the presentation, and I'll kind of come back to this at the end, and you let me know if you think I've made a case for this. But it is my humble opinion that it's the nexus of implementation science and behavioral economics where we have real potential to move the needle in health and healthcare equitability. And I'll make my case throughout, and we'll see what you think at the end. So just to remind us all, when we typically think about how health systems, community, clinics, practice settings make decisions, Typically, a group of smart and well-meaning people sit around a table, discuss a problem, maybe use some data, and make a decision. And often implementation decisions are being made hundreds of times a month, a year, without the benefit necessarily of an implementation science lens. We also know that health systems and practice settings tend to be complex, multi-entity organizations. There's been tremendous headwinds for many years facing these settings, and implementation science offers them insights that could be helpful in achieving the quintuple aim. And we know that healthcare settings are striving to provide high quality care, be operationally efficient, make sure their workforce is well, make sure that all patients have access to their services, and ensure equitable care. Because we know that implementation is hard, we should give it the proper attention it requires. There's an important paper in implementation science in 2023 by Ali and colleagues that offers that across over 1,000 implementation attempts in the database that they've created, most implementing sites, up to 85%, discontinue before achieving program startup or competency. That means that most implementation fails. So it's really important that we bring the best science to thinking about how to implement innovations and evidence-based practice. I personally think that closing the gap between discovery and implementation may be very well one of the most meaningful challenges of our time. This publication in Science by Procter and Gang really, I think, put us on the map for the scientific community that COVID-19 has shown the world that knowing what to do does not ensure doing what we know. There have been several pieces in PNAS, JAMA, describing the importance of implementation science as a discipline. And in the top right is one of my favorite papers to share by Paul Thiel and colleagues. This is a simulation study published before the emergency use authorization for the COVID-19 vaccine. And in this study, they demonstrated that the set of implementation factors would be more important for ultimate impact, reach, effectiveness than the biological efficacy of the vaccine. And of course, in hindsight, we can see how that entire situation played out. But I think we spend so much time on discovery and mechanisms and efficacy, and then we pay very little attention to implementation. And so it's great to see that the scientific community increasingly, as evidenced here, sees implementation as a worthy discipline of focus. What do I think implementation science is? I think it's about making sure that all people are getting the things that work in whatever setting they present to and moving the needle equitably in health. Or as my colleague, Dr. Jeff Curran likes to say, we help people and places do the thing and close no-do gaps. This is a heuristic which my colleague, Dr. Megan Lane Fall, Dr. Jeff Curran, and I developed to help people think about where their work falls on the implementation science subway. It's often a helpful way for people to think about what is and what isn't implementation science. Often we start with a no-do gap, identify a practice of interest, and ask if that practice of interest has been tested in tightly controlled studies that have prioritized internal validity. If the answer to that is no, we're earlier on in the translational continuum where you can absolutely and you should design for implementation, dissemination, sustainment, but it's earlier stage. The next set of questions we might ask is whether or not the practice of interest has shown effectiveness, meaning has it been tested in real world environments with real world clinicians and patients that don't have exclusion criteria. If you're doing that work and not looking at implementation outcomes or implementation processes, that by itself is actually not implementation science. That's effectiveness research focused on patient outcomes. Implementation science work lives in the sweet spot of this green part of the subway, where we're either doing hybrid studies, where we're looking at whether a thing works in a context for patients and looking at a host of implementation outcomes, like how well a clinician implements a particular practice. or how hard or easy it is to implement. And then the bottom is our kind of bread and butter implementation science work. So understanding context, designing implementation strategies based on that context, and then testing those strategies. One more slide on implementation science, and then I'll jump into the behavioral economics content. This is something newer that I've been thinking about as I strive to explain implementation science in a way that makes sense to everybody that I talk to, not just the scientific community. So to me, our science offers a generalizable process that can complement approaches already used by health systems or community settings. But said another way, we're really detectives or consultants. We go into context, we understand if there's a gap or a problem, we think about what thing we have available to us in our toolkit that could solve that gap or problem, do some work to understand what might make it hard, what might make it easy to implement, create a blueprint, evaluate our implementation, and then sustain. And at the core of everything that we do is engagement, or making sure that we know who our constituents or stakeholders are in our environment and bring them along in the process of implementing. I'm going to skip that slide. I've just told you a lot about implementation science. Hopefully it isn't new information for folks, but I do think it's valuable for level setting. So you may wonder, about the behavioral economics part of this presentation. I have come to believe in the work that we've done that behavioral economics can boost or supercharge our approaches, and that it's a really important component of our toolkit that I hope to see lots more folks using more regularly in their implementation, science, and practice endeavors. So how did I come to be interested in that intersection of behavioral economics and implementation science, you might ask? This was a very humbling headline after I completed a 5-year study in close partnership with the city of Philadelphia, focused on implementing cognitive behavioral therapy for young people in the city. And there was a policy infrastructure created to support evidence-based practice delivery. And actually, there was great success in supporting clinician behavior change within organizational constraints, which is broadly how I think about implementation science. Change was still slow. And I ultimately ended up spending about a decade really working closely with the system, trying to understand how to support people and places in doing evidence-based care. We did lots of mixed methods work. We were able to show that there were increases over time in use of evidence-based practices, and which determinants at the organizational level and the individual level were predictive of use of evidence-based techniques. But the qualitative interviews really, they were in the back of my mind. They were keeping me up at night. It was a little bit of an existential crisis. We coined this idea of Maslow's hierarchy of needs for community mental health clinics, where we heard administrators, policymakers, clinicians saying that their top priority was keeping the light on, staying compliant with regulations, retaining their workforce. And while everybody was excited and wanted to deliver the highest quality care and add evidence-based practices to their repertoire, it kind of felt like self-actualization, and that it was very challenging to do so. And so I started to wonder if there was a different way that we could be supporting clinicians and organizations in implementing evidence-based practice, because sometimes I worried that in the effort of implementing, sometimes it was making jobs harder. So that was kind of an existential crisis that I was grappling with after doing implementation-related work with a lot of depth in one system focused on mental health. I was very fortunate when I was at the University of Pennsylvania to be in a very fertile environment for thinking about behavioral economics. So at Penn, the Center for Health Incentives and Behavioral Economics, which is led by Kevin Volpe, was doing really exciting work at thinking about how to advance an agenda in behavioral economics in health, which previously was really more centered on topics like retirement or organ donation. And so I had the great opportunity to partner with colleagues who were experts in behavioral economics to start integrating these concepts together. And I see great synergies with how they can come together. Okay, so what is behavioral economics? I do want to start by clearing up a common misconception. And I admit I had this misconception myself when I started being interested in behavioral economics. It is not financial incentives. So often when people hear me say behavioral economics, they either think I'm talking about health economics, so like cost effectiveness research, or that it means if I pay someone to do something like implement a new practice, they'll do more of that practice. That's actually not at all what behavioral economics is. So I'm going to show you what it is to really bring it to life. So these are just a few favorite examples. What you see here is a subway station in Stockholm as part of a campaign for Volkswagen in the 2000s. These stairs were repainted to look like a piano, like, chopsticks, think chopsticks, including sound. So what would you choose if you were coming out of the subway and you're able-bodied and you had the option of the escalator or these stairs that now played chopsticks? It turns out that during when you do an experiment around this, many more people will choose the stairs over the escalator because of the element of fun, surprise. Here's another favorite example. If we were all together in the room, I would ask you if anyone knew what this is, but we're not. So I'm going to zoom in here, and call out that little dot in the urinal is a fly target. So the story here goes that at this airport in Amsterdam, often people who use the bathroom were not tidy, and it was often dirty. And a fly was painted into the urinals, at reducing spillage by a large percentage. Here's another great example from London. So here, smokers are encouraged not to litter by asking them to vote with their cigarette butts on who the best player in the world is, Ronaldo or Messi. And evaluation suggests that this reduces litter. Again, it's making it attractive, easy, social, to engage in the health promotion behavior that we're looking for. Now, of course, a health promotion behavior would be reducing smoking, but in this example, it was around litter. Finally, I want to give you an example from digital nudging. So if we were all together, I'd ask you to raise your hand if you've ever gotten stuck in a session of watching shows on Netflix. Actually, they leverage the power of the defaults to nudge you to continue watching because it just keeps playing until you turn it off or you say stop. And as humans, we are inclined to go with the default. So here's another example of behavioral economics principles in play. Yes, Amanda. I think I saw your hand raised. Amanda English, did you have a hand raised or am I good?
It was an error.
Okay, awesome. Thank you. So that all hopefully paints a picture for you all around some of the thinking that predated the work that our team did at the intersection of behavioral economics and implementation science. I did a lot of hard reflection and thinking and felt that often in the work that we did, there was this kind of implicit assumption that clinicians just need to work harder by doing evidence-based practice. But having spent a good amount of time in community mental health clinics, all the clinicians I worked with and saw were working really hard, and adding evidence-based practices often just made their life more difficult. So the big idea here was, can we use principles from behavioral economics and choice architecture, which means designing the environment to make the right choice, the easy choice, to make it easier for clinicians and organizations in healthcare settings. This slide is a helpful kind of way to understand the evolution of how we've come to understand behavior change. keeping in mind that implementation science is about behavior change within organizational constraints. But again, the behavioral economics and implementation science literatures really have developed in parallel and not in silos, in parallel and in silos. So right now I'm kind of describing how behavioral economics has kind of come to be. So in the early days, the thinking was, people just don't know, so they can't make optimal decisions, right? So that the idea behind that is if you know that exercise is going to extend your life by 10 years, then you'd be more likely to go to the gym every day after work. The kind of second round of understanding around behavior is this thinking from kind of rational standard economics that we are kind of situated to maximize utility or value in decision making, and that we have kind of complete insight into how we will make decisions. So if that's the case, then you would hypothesize that if you give rewards or financial incentives for behavior, that behavior will increase in a dose response effect, which is actually not the case if you look at the literature. And so behavioral economics arose kind of in reaction or following that way of thinking to argue that we actually as humans behave in predictable ways, and that our brains have evolved to use heuristics to make decisions, and that the environment and context that we're within also has an outsized impact on our behavior and decision making. And so I would argue that implementation science is kind of more in the behavior 2.0 frame right now. And I'd like to see us move more towards incorporating some of the concepts from behavioral economics and how we understand clinician or human decision making within the context of implementation behavior. So what does that mean? Essentially, what it means is that we should design our science less for the ideals of human behavior or how we imagine people should behave, and more for the realities of human behavior. And for anyone who's been in a public health department or in a clinic in a hospital knows that our environments are very contextually driven and messy, and there's a lot happening at any given moment. There is some theory that guides this if you're interested, bounded rationality and dual process theory. But when we are making decisions and behaving in our environment, we often have incomplete information. We have huge constraints on time and resources, and we've evolved to use these mental shortcuts, and that these patterns can be harnessed to design more effective implementation strategies, or supercharged. So just a little evidence that these patterns that I'm describing actually do affect our behavior as clinicians. I'm trained as a psychologist and have practiced clinically during my career. And so this is a paper that came out of the Nudge Unit at Penn in 2019. What you can see on the x-axis is primary care visit appointment time, and what you can see on the y-axis is patients eligible for breast cancer screening. And the blue line is clinician ordering of the screening, and the orange line is patient completion of the screening. And what you see here is a very predictable pattern where over the course of the day, there's less orders and less completion. And that could be because of falling behind for sure, but it also has to do with decision fatigue and choice overload. We also see it in other professions. So for example, judges, there's a very similar curve where at the beginning of the day, they're the most lenient in their sentencing. That reduces over the course of the day until lunch goes back up, and then the line goes back down. So this is evidence that we, as clinicians, display predictable patterns of behavior that reflect our humanness. And this study by Dr. Mitesh Patel and colleagues, and this is also out of the early days of the Nudge Unit, really was one of the first studies that very much caught my attention and really well illustrates the default bias, which is one of these known principles of how we behave and make decisions as humans. So what you can see here on the x-axis is different dates in 2014, and on the y-axis you see the percentage of medications ordered as generic. Prior to this date, 11/15/2014, there's a lot of heterogeneity in prescribing behavior. As of that special date, there was a change made to the electronic health record where the default became the generic medication. And what you see here is a very elegant depiction, and this is a beautiful graph. I've never seen a graph like this in my own work, but it's certainly inspiring, where you see much less heterogeneity after that change to the default in the electronic health record. And most importantly on this graph is there's a green line that I hope you can see that looks different than the clumping of lines on the top, and that's for Synthroid, which is a drug where clinicians prefer to prescribe the name brand formulation. So clinicians were able to change from the default, so maintaining their agency, to Synthroid as a non-generic option. The FOG behavior model is helpful in helping investigators, people consider when solutions from behavioral economics might be most useful. I don't want your takeaway. These intervention or implementation strategy approaches are very fun and attractive, and they seem simple and scalable, and they are. But I don't want you to take away that everything should just then be addressed by behavioral economic informed strategies. Certainly when you want to pull out these strategies, you want to make sure people are motivated and interested in making a change. They have the ability to make that change, and they need some kind of nudge or push or prompt to use that sort of solution. Those are the kind of preconditions that make it most likely that this sort of solution would be helpful. So now that I've kind of laid the groundwork for what behavioral economics is, I'm going to give you a bunch of examples from our work and other people's work to really bring this to life. And this is really disease agnostic. You'll see that these methods can be applied across lots of different disease areas. And I'm going to bucket them into four. I guess I like bucketing things into four. So I'll start with talking a little bit about how we've brought some of the methods approaches from behavioral economics into some of our implementation science approaches to bring some new tools and further deepen participatory approaches. And then I'll give you some examples of implementation strategies that are really focused on clinician behavior, then some that are targeting both clinician and patient behavior. And then I'll end with a study where we tested a behavioral economic or nudge-based strategy to another strategy in implementation science that's often used, facilitation. So going beyond just using these kinds of tools to wrap around an implementation initiative. Okay, so let's talk a little bit about some of the tools and methods we've pulled from behavioral economics and applied within the context of implementation science to advance our goals. So the first way in which I think this can be super helpful is thinking about our implementation strategies. And there's some really useful recommendations from the EAST framework. So make it easy, attractive, social, and timely. And this framework comes out of the UK Behavioral Insights team. When we think about implementation strategy design, often my experience has been that in implementation studies, we kind of pick a kitchen sink approach, and we don't always think about these principles when we're designing our strategies. And they're also relevant actually for the interventions or the things that we want to deploy. So what do I mean by make it easy? I mean, take away all the intermediate steps that you can and make it as easy as possible to do the behavior. Get rid of sludge. Defaults are a great example. If you go back to that example from the default to generic medication prescriptions to shape a desired behavior. And that, just remember the Breaking Bad Netflix example as the synonymous with the default principle. Make it attractive. So you want to use design principles to make optimal choices stand out with colors, bold text, or personalization. So if you're developing a behavioral economics implementation strategy in the electronic health record, that's where many of these strategies are deployed. Make sure you're being really thoughtful in how you design that clinician decision support tool. Make it social. So making it social means leveraging social networks to create peer pressure support. So for example, audit and feedback with peer comparison would be an example of making it social. There can be backfire effects there. So it's really important to design very carefully and understand your context. But in thinking about some of the examples I gave earlier in the talk, voting on Ronaldo versus Messi, or if everybody's kind of playing the piano at the same time, those are ways that those solutions were social. And then, of course, timely, which is a tried and true behavioral principle. Consider when people are going to be the most receptive to these kinds of choice architecture reminders or prompts. I'll show you an example in a bit where we sent text messages to patients prior to an appointment where they were meant to have a serious illness conversation. You'd want to send that text right before the appointment versus a week before, because people are most receptive immediately prior to the behavior that you're looking for. So there's a whole host of other implementation strategies that we could be drawing upon that are not frequently represented in the implementation science literature. In this paper led by colleague Dr. Brianna Last, they lay out the nudge ladder, which provides some additional options that I think are helpful for everyone to have in their toolkit. You can see at the top, and this is highlighted in the review that they led, the default tends to be our most potent strategy. It's not always viable, but when we can do a default, it can be a really strong way to shape behavior. Another tool from behavioral economics that I had not been aware of until I started spending a lot more time in behavioral econ circles is the premortem. So I think premortems can be super helpful when you're trying to de-risk during implementation strategy design. So it allows you to leverage the power of prospective bias and imagine that something has failed before it fails, and then why, and then it allows you to deploy mitigation strategies. A team of us actually did a premortem for the field of implementation science a couple of years ago, and it was a helpful kind of exercise to think about what could go wrong and how we as a field might address those. We're using premortems right now in a NIMH-funded alacrity. So there are 3 projects focused on early mental health. This is a P50 led by Dr. Lori Wachschlag and Dr. J.D. Smith. And so for each of the projects in this Alacrity Center, we are doing a premortem to try to maximize the likelihood of success of the project with an eye towards a bioethics framework. So we're integrating bioethics and the premortem approach. Another really helpful method that we've used across a number of our studies from the behavioral economics literature is our innovation tournaments. So innovation tournaments are like American Idol, but for ideas. So you can think of it as like rapid crowdsourcing of innovative ideas directly from end users. We've used these a number of different ways over the years, but this was our first time deploying the innovation tournament pictured here with frontline clinicians across the city of Philadelphia, asking them, how can your organization help you use evidence-based practices, versus assuming that we knew which implementation strategies would be most helpful to them. And it ended with a big gala and celebration of all the participants, and really allowed us to engage clinicians in ways that we hadn't done previously. The final tool I'll call out that I very much have appreciated from the behavioral economics literature are discrete choice experiments. So you may be familiar that we often ask people to tell us how feasible or acceptable our thing or our implementation strategies are as kind of a test of how it will go when we go to implement. And that can be really useful for lots of good reasons, including constituent engagement and obtaining information about our strategies. But I've often found that we tend to get a truncated range on a Likert. Most people find most of our strategies feasible and acceptable, but then when we go to implement, that doesn't always go that way. So discrete choice experiments are a way to elucidate stated preferences where you basically present blocks of strategies or options to a constituent over several iterations, and they have to pick whether they prefer A versus B, A versus C in a kind of repeated cyclical fashion. And the output of these discrete choice experiments, a subtype is called the best worst scaling experiment, which is what we have below, is you can actually get a numerical kind of rating of how much someone prefers a particular type of strategy. Now, preference is not synonymous with effectiveness, but we've found this to be a helpful tool to really kind of push people to have stated preference for different strategies. And you can see one example here from dermatology and another example from our community mental health work. Okay, so I'm going to give you one example of each of these studies, and then we'll get to the closing part, and I'll make sure we have time for questions. So now I'll give you an example of a study that uses behavioral economic implementation strategies really focused on clinicians. And this is work led by Dr. Steve Purcell, who's a professor here at Northwestern. I'm actually not involved in this study, but I thought it would be nice to pull a couple of examples from across project teams. The focus of this project was reducing care overuse in older patients aligned with the Choosing Wisely guidelines. So there were three kind of things that this project was focused on reducing overuse around. One is PSA testing for men over the age of 76. 2, testing for urinary tract infections without a reason, and 3, overtreatment of diabetes. So they took 60 of our primary care practices here at Northwestern Medicine, almost 400 primary care clinicians, and randomized folks to one of two conditions. This would be a randomization at the clinician level. Actually, sorry, at the primary care level, not the clinician level. So half the practices got just clinician education, so a brief interactive training. Think back on that slide I showed you where that's kind of like behavior 1.0, giving people knowledge and hoping that that will change behavior. But that's our control versus that education plus a clinician decision support tool that directly leverages those heuristics or principles that I was describing earlier. So in that tool, there was a prompt that would come up that noted the increased saliency of the harms of overuse, conveyed that the social norms here at Northwestern Medicine are that we don't do X, Y, and Z, and to promote accountability. So clinicians had to say why they were doing something if they elected to carry forward in something that might be defined as care overuse. And I encourage you to check out this paper. It's well done in Annals of Internal Medicine. Without getting into the weeds of the findings, what you can see is that the intervention or implementation strategy condition that was active reduced PSA testing in older men and testing for urinary tract infection. The effect was smaller for overtreatment of diabetes, but in general, you can see that the implementation strategy arm that was pulling from behavioral economics did better than the control arm in reducing the behavior. Here's an example from our team focused on clinician and patient-facing strategies. This comes from our NCI Implementation Science Center in Cancer Control. This was led by Dr. Sam Takborian and Dr. Ravi Parikh. The thing that we were focused on in this project was early serious illness conversations. In patients that were at high risk to be at end of life in the next 6 months, receiving oncology care. There's good evidence that suggests that these conversations elicit care preferences and improve outcomes. But currently, most patients with cancer die without one of these serious illness conversations documented in their medical record. So we did a 4-arm pragmatic cluster randomized controlled trial. So we tested a usual care condition versus clinicians versus patient versus both, and I'll walk you through each of those. So one thing that's important to know that when we did this trial in the Penn Medicine system, they had already been doing some work related to serious illness conversations that included text messaging and emailing clinicians to remind them to do these conversations. So that was our active control usual care condition. The clinician targeted strategy used the usual care approach plus peer comparison. So let's think back to that EAST framework I mentioned, make it social. You can see here pictured an example of an email with peer comparison with that graph letting a clinician know how their performance compares. We also had a patient strategy where they received text messages, normalizing serious illness conversations, and a 3-question priming survey. You can see some of these questions on the slides. And then the condition that had both included both the patient and the clinician nudge. So there were 4,400 patients engaged across the 4 study arms. And essentially what you can see here is that the condition that included both the patient and the clinician targeted strategies resulted in higher rates of serious illness conversation completion. And that makes sense conceptually, right? Because the conversation is a dyadic interaction between a patient and clinician. Remember, the clinician nudge alone was just kind of being added on to an existing active control. So, I wouldn't expect to see a huge effect there. And in a different health system where they weren't doing those to begin with, there might have been a greater effect. And so the final example I'll give you is going beyond nudges. And one of the really interesting things to think about is like, when do you use these approaches and how do you decide if you're just going to target the patient or the clinician or both, or pull in different strategies from implementation science? My personal opinion is that nudges are part of our toolkit, but not the only tool in our toolkit. I'll share with you a study that we are just about completing, the ASPIRE trial, where we tested a behavioral economic strategy or nudge, where we changed the electronic health record documentation template for the well-child visit versus that plus more intensive facilitation, which is a well-known implementation strategy, to see if that more intensive support was needed to overcome implementation barriers. And our thing in this study is secure firearm storage. So we were working to support pediatricians in pediatric primary care to deploy this very brief secure firearm storage program. And we did this work in partnership with Kaiser Colorado and Henry Ford Health. This was a hybrid type 3 trial. We were in 30 clinics with almost 400 clinicians and over 45,000 well-child visits. Half of our clinics just got the change to the well-child visit template documentation. The other half of our clinics got that change to the electronic health record plus 1 year of facilitation. I'm going to show you what I mean by that so that it really comes to life. So the thing here is this program called Safe Firearm, which includes a brief harm reduction informed conversation between a pediatrician and a parent, a handout about secure firearm storage, and an offer of a firearm cable lock for free within the context of the well-child visit. So that's what we were trying to implement. And to implement that program, our strategies included the change to the electronic health record documentation template. Here's an example of what that change looked like in the EHR, as well as our Nudge Plus condition, which included facilitation. And in our study, facilitation included developing a plan for implementation in each clinic, coaching and instruction, audit, and feedback. So to orient you to this, these are the main outcomes from this study. You can see on the x-axis each of the conditions. On the y-axis, you can see reach, which is the percentage of families who received the whole intervention. So the discussion of safe firearm storage plus the offer of a lock over the number eligible. And what you can see here is that patients presenting to clinics who got facilitation were 2.2 times more likely to receive the whole program. So almost 50% of those well-child visits had received the whole safe firearm program. And what's notable is that at baseline, very few pediatricians are doing a program like Safe Firearm. So, this is a pretty meaningful change. Even just with the electronic health record documentation template change, we jumped to around 22%. And then again, the addition of facilitation, which was, support from expert personnel in the health system, doing 10 hours of work per clinic over the year, so less than an hour a month, jumped up to 49%. So I'd say this is pretty robust behavior change. We still have a lot of ways to go, but to go from about 2% to 49% feels pretty meaningful. We're doing lots more work in that area, including implementing in health centers in Illinois, as well as scaling out to implement in adult primary care and women's health in those two health systems where the service lines heard about what was happening in pediatrics and wanted to scale out beyond. So we'll see if those strategies work within the context of new populations and settings. Lots of other exciting work in this space that our team is involved in across cardiovascular disease, de-implementation. I think the most exciting thing is there's a number of early career investigators on K Awards who are making this a real focus of their area of expertise, this intersection of behavioral economics and implementation science. And I'll just conclude with a few brief words about implications and future directions before opening up for questions. So I just spent an hour telling you all about behavioral economics and how important it is to integrate these approaches into our toolkit and implementation science. But I would be remiss in not calling out that we cannot be only using these approaches. It's not a panacea. There have been some critical reviews of behavioral economics in recent years, probably the most well-known one by Chatter and Lowenstein below, related to this idea that when we focus on individual level solutions for structural or systemic problems, that's suboptimal. And often behavioral economics can be kind of perceived as an individual level behavior change strategy when often there's structural changes that are required. In terms of other exciting potential directions, I'd love to see us incorporate more of this thinking into our existing taxonomies in implementation science. The ERIC taxonomy, consolidated framework for implementation research. There's opportunities to bring this thinking into many of the approaches that we commonly use. I think it's an open question still, like when you use which type of approach and which principle. And in my mind, behavioral economic strategies can be first line approaches coupled with other strategies in a stepped fashion, making sure to address multi-level barriers. There is some good preliminary evidence that behavioral economic implementation strategies work across subpopulations that experience disparities. So there is some potential there around reducing inequities, and I'd love to see more work explicitly centering those questions, and more work understanding if taking this kind of approach crowds out opportunity for structural approaches. Interestingly, behavioral economics as a field has recently called out their desire to scale their findings so they can benefit from implementation science also. I see Dr. Fernandez, so I'm going to just take us to my main takeaway, which is that I hope you have seen that this nexus is exciting. And I like to close with a slide that calls out some of the folks who are doing creative and transdisciplinary work in implementation science who are earlier career that represent the future of our fields, and thank those who make this work possible. And I will stop now.
Thank you so much. That was amazing. Really appreciate it. So we have a couple questions. I know we don't have much time, but the first question is, what formal or informal behavioral economics training would you recommend for implementation scientists who want to develop expertise in this area?
Yeah, that's a great question, because I will say it was humbling kind of getting up to speed on an entirely new discipline after kind of training in implementation science, which is humbling in its own way because most of us didn't do that training in graduate school, at least our generation. So there's a lot to get up to speed on. The Center for CHIBE, the Center for Health Incentives and Behavioral Economics, has some good resources online for training opportunities. I also think the best way to learn a new discipline is to apprentice with people who are doing that work. That's really how I learned. Was didactics were helpful, just like knowledge helps a little bit, but you actually got to get in there and do it to apply it.
Great. And there's another question. When designing a behavioral science trial that uses patient-directed nudges, how do you account for heterogeneity in clinical presentation, risk factors, or underlying psychopathology?
Yeah, I mean, I think that there's a growing literature on kind of behavioral phenotyping and trying to understand that heterogeneity in original presentation, and then trying to tailor like individualized nudges based on how people present. But also when we're using a randomized control trial, typically we do have some heterogeneity that will be distributed across study arms. And that's why we do a power analysis to make sure that we're able to answer a study question, taking into account some of that heterogeneity and distributing across study arms. But there is a growing literature on this idea of precision nudges that I think more work needs to be done in.
Yeah, and this is a related question, and I think you mentioned it when you were wrapping up. The question is, do you see a difference in effectiveness or consistency in results as it pertains to demographic differences, age, gender, race?
I couldn't I did such an overview there. There's not like a generalization that I can say that this works better overall for one group or other. I think it really depends on the study at hand and the population, the context, the intervention. So certainly we do see effect modifiers in studies that we do in this space, but I can't take a step back and say consistently one of those demographic factors is a standing effect modifier for effectiveness of behavioral economics approaches.
And then I see another question. When incorporating behavioral economics principles into clinical trial design, especially around participant compensation, how do you account for the possibility that universal incentives may not influence decision-making or trial outcomes?
Yeah, well, I mean, designing incentives for trial participation is its like own area of focus. And I've been seeing a lot of interesting recent studies that are basically trials within a trial, trying to determine how modification or changing incentive strategies might influence trial outcomes or recruitment and participation. I can say that, and I don't know if I'm exactly answering the question. I'm not sure I fully understand the question, but we do, before we start every trial designed in this way, do a pilot and try to test different kind of incentive strategies to ensure that we can get the most representative population of participants. So we do try to use these principles also in our design of the actual trial.
Yeah, and oh, sorry, go ahead.
Yeah, no, I just wanted to jump in here, Marie. I think this is where the distinction you made about financial incentives or behavioral economics being about financial incentives and more really comes to play. I mean, what I'm reading in this question is about the use of behavioral economic principles in clinical trial design, but the question is more about participant compensation to participate in clinical trials. So perhaps there is that and other reasons or other behavioral economic principles to further increase participation or speak to other reasons people will participate in clinical trials. It's a very nuanced question. I appreciate that, but I thought that distinction plays out here really well.
Yeah, and some colleagues at Penn have a AHA-funded center, the Better Center, where they're testing different behavioral economic principles for clinical trial participant engagement and recruitment. So that might be a good place to look for that question.
And we're just about out of time, but I do want to float one more question, and if we don't have time to answer it right now, that's okay. But so I know that you know about implementation mapping, since you're one of the authors on that 2019 paper, and how we link methods with determinants of implementation, right? So we understand what's happening and then sort of choose methods. What sorts of determinants are addressed with the kinds of these sorts of methods using behavioral economics, or is it more focused on context than actual factors influencing implementation at a personal level?
I think cognitive load is one that is like very well represented as a determinant. And if you think about like the East framework, if you were to use the East framework, and I'd love to continue this conversation, like I think it's a really, really interesting question. But if you think of the East framework as like the solutions side, like what is that solving? What are the determinants those are solving for? Like ease really has to pertain to cognitive load, right? Peer comparison is activating social networks and one's identity. So I do think that there are individual level determinants, as well as this idea of we need to use choice architecture to make the right choice, the easy choice. Like just like we put the apple by the cash register when we're going to get our lunch versus the bag of chips. It's that same concept at the kind of context, the environmental context level. Those would be the determinants. But I think we could have a very fun conversation about this and would look forward to that.
I'd like that. Well, thank you so much. Thank you for everyone for attending. The recording and slides will be available on our website. And thank you for just a phenomenal kickoff to our seminar series, Dr. Beidas.
Thanks for having me. Good to see you all. Great
Thank
questions,
you.
everyone.